In the New England Journal of Medicine is an interesting perspective on interpreting the coronary artery calcium score. It begins with the story of a 55-year-old man without coronary risk factors who responded to a newspaper ad of all things 6 years ago and had a coronary score of 39. Very comforting. Now on repeat scan, his score has increased to 119, and the issue is how to interpret this and what to recommend for treatment, if any. The abnormal calcium score should simply be viewed as documentation of coronary atherosclerosis, the appropriate treatment for which is, of course, lifestyle modification, reduction of blood pressure and LDL cholesterol levels, and antiplatelet agents. Remember that in acute coronary syndromes, the culprit lesion may be a non-calcified plaque characterized by plaque burden with a thin fibrous cap and a small luminal area, not coronary calcium. Therefore, the areas of coronary calcium visualized by CT are not necessarily the same lesions that cause subsequent coronary events. In considering these questions, it's important to evaluate the calcium score within the clinical context. As a rule, data from the multi-ethnic study of atherosclerosis and other trials suggest that a calcium score below 100 indicates low risk and a score above 300 indicates high risk. So our patient is abnormal but at the low risk end. An abnormal calcium score in an asymptomatic patient is not an indication for coronary angiography, nor are stents or bypass surgery indicated to treat coronary calcification. So what to do? The article points out that a stress test can be helpful in patients with abnormal scores to evaluate functional capacity and the presence or absence of ischemia. It can also help to reassure an anxious patient. Although the calcium score has not been shown to affect outcomes, it can be useful in encouraging medical compliance. A recent randomized trial demonstrated the subject who underwent calcium scoring before counseling about risk factor modification had greater improvements in systolic blood pressure, LDL cholesterol levels, and waist circumference than subjects who did not undergo coronary calcium scoring. The perspective also tells us the rest of the patient's story. He had a stress echo done, exercised for 13.5 minutes in accordance with the Bruce protocol, and had no symptoms, ECG changes, or wall motion abnormalities. He was given dietary instruction, prescribed 325 milligrams of aspirin daily, and his statin dose was increased to 20 milligrams a day. I'm Peter Block, and this is a CardioSource Heart Minute.